everybody knows about the endocrine glands. There are a lot of endocrine glands, though major one is, of course, one is pituitary and hypothalamus. Coming down, there are other pituitary glands, other endocrine glands like thyroid glands, parathyroid glands, and even adrenals, testes, ovaries, and all things. So today we are going to talk about the diseases related to pituitary and the some physiology and anatomy related to pituitary. I hope everybody know about the anatomy regarding the brain and its structures and the bones related to it. So there is a bone called sphenoid bone. The sphenoid bone ko एउटा part हो sella turcica, which we also call turkey saddle, and it just underlies the base of the hypothalamus, and there is anterior clinoid process and posterior clinoid process, and at the top of it there is a part of dura mater which we call diaphragm sella, which prevents the CSF, the cerebrospinal fluid, to enter inside the sella turcica. So just above it, there is optic chiasma, and there is cavernous sinuses. So you need to know about the relations of anatomical relations of sella turcica, because when pituitary gland enlarges, then this enlargement of pituitary gland may affect these structures and may present with the symptoms related to that. So pituitary gland usually weigh about 1.5, 1.0 into 6 millimeter in size, which is around just less than 1 gram, and may double in sometimes in size during pregnancy. And pituitary gland is supplied by the parts or branches of internal carotid arteries, which we call superior, middle, and inferior hypophyseal arteries. So you can see here, this is a sphenoid part of sphenoid bone, which we call sella turcica inside. So within sella turcica, there is anterior lobe, and there is posterior lobe of the pituitary gland. And just above it, there is one part, we call it optic chiasma, and there is part called diaphragm sella, which is part of dura mater, which covers the pituitary sella turcica, that prevents cerebrospinal fluid to come down. When this is damaged, sometimes cerebrospinal fluid may come down, and it may compress the pituitary gland, causing hypopituitarism or pituitary secretory dysfunction. And just above it, there is median eminence as a part of hypothalamus. You can see pituitary stalk, and there is internal carotid arteries having superior hypophyseal, middle hypophyseal, and inferior hypophyseal arteries. These all three branches supply pituitary gland, and also you can even see in this picture, we can see that there are parts of hypothalamus. There are multiple nucleus of hypothalamus. I hope everybody know about the function of hypothalamus. It controls satiety, it controls temperature, it controls weight and all things. And the major nucleuses like supraoptic nucleus, paraventricular nucleus, which is called magnicellular nucleus, and the dorsomedial, ventromedial nucleuses, and mostly supraoptic, preoptic, and paraventricular nucleus have their axons, which comes down to the posterior lobe. So the posterior lobe is bundle of axons, which is the extension of hypothalamus. So anterior pituitary or adenohypophysis embryologically originated from the Rathke's pause. It is an ectodermal evagination anterior to roof of oropharynx, whereas posterior pituitary we also call neurohypophysis. It arises from the neural ectoderm, that is just from the right third ventricle. So it's also a collection of axon terminals rising from the magnicellular secretory neurons located in paraventricular nucleus and supraoptic nucleus of the hypothalamus, and it secretes substances like vasopressin and oxytocin. So these are the hormones that is secreted from the anterior pituitary hormones that are somatotropes, which secretes growth hormone, ultimately helps in the production of insulin-like growth factor and helps in actions on growth and metabolism. Whereas lactotropes or mammotropes, which secretes prolactin, prolactin helps in milk production and inhibits gonadotrophin. And there is corticotrophs, which secretes pro-melanocorticotropic hormones and adrenocorticotropic hormones and beta-LPS hormones, which ultimately helps in a secretion of corticosteroids or sex steroids from the zona fasciculata and zona reticularis simultaneously. And there is thyrotroph, or we call it TRS. So somatotroph, we can say that gonadotrophic growth hormone releasing factor, releasing hormone, अथवा GHRH. And lactotroph, we call it prolactin releasing hormone. And then corticotroph, we call it CRS, corticosteroid releasing hormone. So thyrotroph, TRS, thyrotropin releasing hormone, that secretes TSS, thyroid stimulating hormone, which helps in production of thyroid hormones. Gonadotrophs, which helps in production of LH and FSS from anterior pituitary, luteinizing hormone and follicle-stimulating hormones. I hope you know about the functions. There is different functions regarding females and males. In females, luteinizing hormone also helps in stimulation of steroid hormone synthesis and lutein cells and Haller cells, and helps in menstruation. In males, stimulates steroid hormone production in Leydig cells, and follicle stimulating hormone in females. There is a different function which helps in follicular development, and in males, in cells means spermatogenesis. So the hypothalamic hormones यसमा पेमेन्ट गर्नुपर्छ फेरि कन्टिन्यू गर्न मिल्छ नि हैन
सर फेरि यही लिंकमा रिजोइन गर्दा हुन्छ
मिल्छ सर यसमै अहिले 10 मिनेट टाइम छ सर अनि पछि रिजोइन गर्ने सर
So hypothalamic hormones, posterior pituitary and anterior pituitary. Anterior pituitary को अहिले भर्खर मैले भने त TRS, GNRS, GHRS, and then prolactin releasing hormones and corticotrophic releasing hormones अथवा prolactin releasing hormones भन्दा नि there are other hormones, and posterior pituitary hormones like arginine, vasopressin and oxytocin, and prolactin releasing hormone चाहिँ अहिले हुँदैन. Prolactin secretion is guided by the thyroid releasing hormone. So hypopituitarism, these are the little bit about the basics of pituitary. So pituitary को disease हरू चाहिँ mainly चाहिँ it may be hypofunction अथवा it may be hyperfunction, or it may be there may be association of mass अथवा tumors, right? Pituitary tumors एउटा, pituitary hyperfunction and pituitary hyperfunctions. So hypopituitarism defines as deficiency of one or more pituitary hormones. If two or more hormones is deficient, then we call it panhypopituitarism. So there are a lot of causes of hypopituitarism. That is, it could be invasive. There are 9 I's. 9 I's means invasive, infection, infiltrative, injury, immunologic, iatrogenic, infection, idiopathic, and isolated. So invasive means tumors. When there is production of when there is a tumor in pituitary gland itself, or a tumor from the outside the pituitary gland, भनेको लाइक आउटसाइड द पिट्युटरी ग्ल्यान्ड लाइक क्रानियोफेरिन्जियोमाजहरु अथवा मेलिग्नेन्सीहरु के मेटास्टासिसहरु अथवा पिट्युटरी एडिनोमा इटसेल्फ भयो भने के हुन्छ पिट्युटरी सेल्स विल गेट कम्प्रेस्ड अथवा पिट्युटरी सेल्स विल बी ड्यामेज्ड त्यसले गर्दा फेरि देयर विल बी पिट्युटरी हार्मोन डेफिसिएन्सीज सिमिलरली इन्फेक्सन्स दैट मीन्स द सेल्स अथवा टिश्यूज इज के भन्छ loses their blood supply and it dies so there will be loss of pituitary hormone deficiency like Sheehan syndromes, diabetes mellitus, and pituitary apoplexis. Similarly, infiltrative like sarcoidosis, hemochromatosis, histiocytosis, injury like head traumas, immunologic like lymphocytic hypophysitis, it is inflammatory disease, and iatrogenic like surgery, pituitary gland ko surgery भयो भने radiotherapy गर्यो भने कहिलेकाहीँ pituitary hormone deficiency हुन सक्छ infection like tuberculosis and syphilis and idiopathic like isolated or combined hormone deficiency कहिलेकाहीँ genetic हुन सक्छ or isolated growth hormone deficiency ACTH अथवा gonadotropin deficiency हुन सक्छ isolated hormone deficiencies हुन सक्छ So cellular and paracellular masses tumor के हुन सक्छ it could be benign pituitary adenoma craniopharyngioma Rathke's cleft cyst meningioma arachnoid cyst rheumatoid cyst similarly pituitary hyperplasia हुन सक्छ malignant like sarcoma chordoma germ cell tumor हुन सक्छ these are different types of masses like metastatic breast long gliomas like optic glioma astrocytoma oligodendroglioma vascular lesions हुन सक्छ granulomatous disease like tuberculosis sarcoid histiocytosis अथवा anticellular syndrome हुन सक्छ these all are the different type of mass that may we encounter in evaluating of hypopituitarism in evaluating during a case of hypopituitarism. So, how will you evaluate a case of pituitary mass? So, if there is a pituitary mass, then patient may present with local mass effects of expanding pituitary, paracellular, or hypothalamic mass. So, pituitary ma euta ke huna सक्छ एउटा hormonal hyperfunction लिएर represent गर्न सक्ने भयो अथवा hormonal hypofunction पनि लिएर represent गर्न सक्ने भयो. Hormonal hyperfunction like acromegaly. When there is excess growth hormone production, that scenario is called acromegaly. When there is excess cortisol production, then there is ACTH production, and which ultimately lead to excess cortisol production. Then the patient may present with Cushing syndrome. Similarly, prolactin secretion excess भयो भने hyperprolactinemia. Similarly, TRS अथवा leading to TSS oversecretion, then it may result in thyrotoxicosis. Similarly, when there is excess LH अथवा luteinizing hormone or follicular stimulating hormone अथवा increased LH before the time of puberty, then the patient may present with precocious puberty. That is puberty before the defined time. So hormonal hypofunction हुन सक्छ hormonal hypofunction like growth hormone deficiency ACTH LH FSH TSS or combined hormone deficiency. If growth hormone deficiency भयो भने growth failure लिएर आउन सक्छ short stature हुन सक्छ ACTH deficiency भयो भने adrenal insufficiency लिएर आउन सक्छ LH FSH deficiency भयो भने patient may have delayed puberty or subfertility infertility हरू लिएर आउन सक्छ TSS deficiency अथवा TSS deficiency लियो भने features of hypothyroidism लिएर आउन सक्छ Similarly, hypothalamic dysfunction कहिलेकाहीँ hypothalamic compression अथवा hypothalamus मै tumor हरू भयो भने there might be temperature dysregulation obesity diabetes insipidus increased thirst sleep and appetite disturbance autonomic nervous dysfunctions हरू हुन सक्छ Then the related anatomic structures हरूमा damage भयो भने के भन्छ like cavernous sinus हरूमा त्यहाँ जुन चाहिँ जहाँ चाहिँ नर्भहरु चाहिँ पास भइरहेको हुन्छ थर्ड क्रानियल अथवा सिक्स्थ क्रानियल नर्भ जुन पास भइरहेको हुन्छ सो त्यो ठाउँमा के हुन सक्छ when that region is compressed then the patient may present with ptosis diplopia ophthalmology and facial numbness similarly temporal lobe when temporal lobe is affected then patient may present with unsynaptic seizure frontal lobe problems like personality disorder anosmia central features like when there is meningeal irritations like headache हरू हुन सक्छ when ventricles are complex patient may present with hydrocephalus psychosis and even sometimes dementia and elastic seizures हरू लिएर आउन सक्छ When the optic tract is compressed, our optic chiasma or optic tract or compressed when visual disturbance or there are a lot of defects, so like loss of red perception, bitemporal hemianopia, scotomas or acuity loss, papilledema, optic atrophy, cranial nerve palsies, nystagmus, and visual hallucinations. So there are a lot of visual problems when it affects optic tract or optic chiasma. So how to evaluate, how should we assess the pituitary hormones? So pituitary hormone deficiency छ भने अथवा पिट्युटरी रिजनमा डिस्फङ्क्सन छ भने हाउ दे माइट प्रेजेन्ट भन्ने कुरा त हामीले पढ्यौं. So it may present with hyperfunction, it may present with hypofunction, or it may present with mass effects. Mass effects like visual disturbance, mass effect like hypothalamic pictures, hypothalamic defects, mass effect like meningeal irritation signs and ventricular hydrocephalus. So hormone deficiency भयो भने how to evaluate अथवा hormone excess भयो भने how to evaluate. If there is hormone deficiency, ACTH deficiency छ भने we have to go for short ACTH stimulation test, or we call it synecthen test. Similarly, we can also go for insulin tolerance test. I will not go to details about it. अब कसैलाई पढ्न मन छ भने चाहिँ यो भित्र गएर आफै पढ्नु होला because it's very complicated and long chapter. Similarly, LH-FSH deficiency छ भने how to evaluate. If it is in male, then we can just go for random serum testosterone, LH and FSH. And in premenopausal women, ask if menses are irregular. Menstruation regular भइरहेको छ भने then we not to have to measure LH and FSH because it defines that menstruation that LH and FSH is normal if menstruation is normal in females. If postmenopausal female, then we have to see for LH and FSH, which would normally be greater than 30. Postmenopausal के हुन्छ FSH and LH rise due to secondary effect के भन्छ feedback mechanism. तर अब secondary के रे postmenopausal women मा LH FSH जुन high हुन पर्ने हो त्यो LH FSH normal भयो भने पनि then we have to suspect that there is LH-FSH deficiency. TSH deficiency ko lagi we have to measure random serum T4. Note that we have to note that TSH is often detectable in secondary hypothyroidism. Secondary hypothyroidism TSH either it would be low, it would be normal, or it would be high. Similarly, we have to measure growth hormone deficiency. Of growth hormone deficiency ko lagi there are a lot of stimulatory tests and even exercise post exercise glucagon stimulation test. There are a lot of things and is time finished boy